Good morning, everyone.
Good morning, Emily.
Thank you. Thank you. I am delighted to hear the conversations going on around the room and to have everyone here. I would like to welcome you to the American Cancer Society Cancer Action Network's 5th Annual Policy Forum. I am Emily Neenan. I'm the Alaska Government Relations Director for the American Cancer Society Cancer Action Network. And we have a really interesting conversation this morning, and I'm so glad that everyone here can be part of it. Part of the reason that we picked this topic is September is Childhood Cancer Awareness Month. And this conversation today is building on conversations that we've had over the last 3 years talking about the subject of palliative care. And if you need a refresher on exactly what that definition is, there's going to be a quiz later, and then we have some experts from the field that are going to go over that. Before we go any further, though, I would like to recognize our sponsors of this event. Our presenting sponsor, the Children's Hospital at Providence, and our gold sponsors, the Alaska Native Tribal Health Consortium, Lyft, yes, that is the ride-sharing company, Bristol-Myers Squibb, Amgen, AARP Alaska, Janssen Oncology, and then a group of students from a social work class last year who did a special project that helped lead into this and actually held their own 5K and to help sponsor this event. So if we could please have a round of applause for our I know that there are some representatives of these groups that are in the room today. Thank you so much for being here. I'd particularly like to recognize the presenting sponsor, Children's Hospital at Providence, and ask that Nikki Snyder, who I've lost, here we go, come on up and share a couple words with us about the Children's Hospital. Thank you.
Good morning. My name is Nikki Snyder, and I am one of the nurse leaders here at the Children's Hospital. Some of the departments I'm responsible for have the good fortune of interacting on a daily basis with many of our pediatric oncology patients. Those areas are inpatient pediatrics, the pediatric ICU, and our sedation program, where many of these children come to have their painful treatments under less painful circumstances. So as I think about children's cancer awareness and having the fortunate experience of watching our program develop since its infancy, what I am most impressed about are the many people that are involved in treating these children that face this huge mountain of childhood cancer. When you traditionally think of a physician or a nurse or what patients come to the hospital for, it goes so much more beyond the medical personnel. We have the child life specialists, the teachers, the therapists, both for mental health and for all of their physical therapies that they need. Even environmental service workers, everybody that helps make the experience and the outcome for these children so much more. And then I also think about research and the funding that goes for this program, and we still have so many more opportunities to focus on that. So few dollars that are raised for cancer research actually go to children's cancer. So I thank all of you in the community, because it's the community fundraising opportunities and donors, such as some of yourselves and some of the community events that we have that raise dollars for childhood cancer, that really make a difference in looking towards the future and fighting these horrible experiences for these children. Thank you.
Thank you, Nikki. Appreciate that. Next, I'd like to just share a little bit about what the American Cancer Society Cancer Action Network is and what we do. We are the advocacy affiliate of the American Cancer Society. So in my world, I think we get to work on a lot of fun things. We actually work on public policy change. We do a tremendous amount of work on cancer research funding. The American Cancer Society is proud to be the second largest funder of cancer research in the United States. And that's great, but the largest funder of cancer research in the US is the federal government. And that's why we work so hard to keep research dollars flowing from the federal government. We also work on the state and sometimes even on the local level as well on a number of things. We have some recent wins. Big news. For a number of years, we have been working to get federal research funding back up to a higher level. It had dropped precipitously over the last 15 years or so, but just in the last year, we succeeded in getting $1 billion in new appropriations to the National Institutes of Health and National Cancer Institute. On the state level, after many years of working around the state at the local level for 20 plus years, at protecting people from secondhand smoke where they work inside their offices. It wasn't all that long ago that people were smoking in rooms just like this, in this very hospital. But we have worked to make sure that all workers across the state are protected from secondhand smoke. Thank you to everyone here who worked on that. And speaking of what Nikki mentioned, childhood cancer research, we also were a part of, with many other partners, in getting the Childhood Cancer STAR Act passed in Congress. We worked on it, and not just ACS CAN, which is the abbreviation for American Cancer Society Cancer Action Network. Not just ACS CAN, but many other partners worked on this for many years. When the time finally came that members of Congress couldn't ignore the issue any longer, it's not actually that surprising that this bill passed both the US House and Senate unanimously. Because how could you not? But it took a long time to get the education level to that point. The STAR Act stands for Survivorship, Treatment, Access, and Research. It will increase funding for childhood cancer research and look at specifically some survivorship issues that are often have been overlooked. What are the long-term implications of having gone through childhood cancer treatment? Expanding data collection so that we can know more, learn more. All of this is because of the people in this room and because of the people in rooms like this all over the country that are working together to make this happen. There will be an opportunity a little bit later on to help us in this effort as we move forward. For now, I would like to ask Tanya Eiden from Agnew-Beck to come up and share with us. We have a fun tool, these little clickers that you may have in your pocket like I did in mine. I'm going to hand it over to Tanya to show us how this works.
Alrighty. Hi everybody, my name is Tanya. I work at Agnew-Beck Consulting, and my colleague Becky is here too, taking some notes today so that we have a log of what everybody asks about and what happens here today. So we are providing this audience response technology, and essentially it's just these, we call them the clickers. So throughout the presentation there'll be a couple of questions just kind of to keep you alert and excited. And you will see the question presented on the slide, and you will have choices that are numbered, and you will press the answer, your answer, with the corresponding number, usually 1, 2, 3, 4, 5. I don't think we have any longer ones than that. And then you always press send. So we're going to warm you up with 2 warm-up questions. If there is multiple responses, so some of them will say choose all that apply, you would click 1, send, 3, send. So just always press send. And if you mess up or you want to change, you can do it again and it'll overwrite your answer. Does that make sense? Any questions? Have you guys all used the clickers before? They're kind of fun. Okay. Becky, would you mind? Oh, let's practice. Okay. This is, what do you prefer, sand or snow? These are your test ones. And then right here you can see we're kind of getting our initial count of maybe how many people are in the room voting. Looks like maybe we handed out, no? Kind of like 40. I think we handed out 46. Maybe they're not all voting. Everybody good? Okay, here we go. The results. Interesting. Half and half room, see? That is actually kind of fascinating. I thought everybody would be like, I guess it's still warm weather here now, so we're not like yearning for the sand yet. Okay, and then the next question is related to you, and this is one of the, oh no, this is your most recent role. Sorry, I thought it was a multiple choice one, but how would you kind of define yourself here today?
Tanya, people may have more than one role, so just pick whichever one.
Yes, with your primary role. The hat you feel like wearing right now, at this moment. And this is where we're actually capturing interesting data from you. We're like, oh wow, there were a lot of healthcare workers at that meeting. I'm sensing we actually only have 40 people really voting, which is okay. All right. And our results. We do have a lot of healthcare practitioners here. So anyways, you're getting a sense of who's in the room here today. Agency partners, interested community members. So that's how they work. Any questions? So periodically throughout the presentation, you'll be asked a little audience response question. You probably won't see me again. Emily from here on out. Thanks.
Thank you, Tanya. While we're doing the who's in the room, I do want to recognize that we have several of our elected officials who have taken time out to be here this morning. Senator Kathy Giesel, thank you for being here. Representative David Eastman, thank you for coming out this morning and driving in. And Anchorage Assemblyman John Weddleton, thank you. We also have our State of Alaska Chief Medical Officer, Dr. Jay Butler, thank you. And I know that there are some legislative staff here as well. Did I miss any legislators or policymakers, any elected officials? Okay. I know that we also have Tristan Walsh, who is staff to Representative Lescara. Thank you for that. Any other legislative staff in the room? Yes.
Carol with Representative Laura Reinbold.
Yes, thank you so much, Carol, with Representative Laura Reinbold's office. Thank you so much for being here. I really appreciate that. Anyone else? Okay. With that, we'll get on to the meat of the morning. We're going to talk about pediatric oncology in Alaska, kids with cancer. What does that care look like? What's the history on that issue? What does it look like now? There's some exciting things that have happened in the last decade. It looks really different than it did a very short time ago. What does palliative care mean, and what does it mean for kids? We're going to talk about resources that are available or needed outside of the hospital setting. We're going to talk some about national models and examples. Our panel has experience in many other states on these issues as well. And here to talk about that, I would like to welcome our panelists. Right here is Ronda Nakoa. She is she's worked at Providence for the last 17 years. She is now a pediatric hematology-oncology nurse practitioner. Cares for a wide array of pediatric oncology patients. She's been working with pediatric oncology patients since 2006, before they even really had a program here in Alaska. So welcome, Ronda. Thank you. Beside her, we have Dr. Kelsey Terland. She joined the Providence, Alaska Medical Group Palliative Care Department just last year. And she hails from Alaska for many years now, since 2006. She was a WAMI student, went through University of Washington medical program, did family medicine in Boise, and then came here to do a fellowship in palliative care. Within palliative medicine, Kelsey has special interest in perinatal palliative care, medical ethics, and medical education. Welcome, Dr. Terland. Dr. Sean Timpane is over here, is here from Alaska Native Tribal Health Consortium. He got his start working at St. Jude's Medical in cardiac rhythm management with pacemakers and defibrillators before going back to school to complete his medical degree at the University of Florida. Go Gators! After a chief residency in pediatrics program he finally came to his senses and came to the University of Washington. Go Huskies! And then also at Seattle Children's Hospital, he completed a palliative care fellowship with the Harvard Interprofessional Palliative Care Program before moving with his whole family here to Anchorage to work at the palliative care department at the Alaska Native Tribal Health Consortium. Thank you. And finally, we welcome Stephanie Fortt, is a licensed clinical social worker working in pediatric oncology here at Providence. She's been in pediatric medical social work for the last 10 years and now works in the pediatric subspecialties clinic. And I didn't ask you your mascot.
Catamounts. University of Vermont.
University of Vermont.
Catamounts is the mascot.
Catamounts. Okay. It must not be a football school. All right. All right. With that, I would like to do a quick quiz before we hand things over to Ronda. What percentage of Alaska kids with a cancer diagnosis can receive all of their care right here in Alaska? Everybody ready? And the results?
And that's telling us what the right answer is.
All right. So, Rhonda's going to tell us about how 90% of kids with a cancer diagnosis can receive all of their care right here in Alaska, which is a big change. So we have one mic. There's going to be a lot of back and forth. If anybody has trouble hearing, give us a holler. Here you go.
Hi there. So when I started at Providence in 2001, the primary role of us on pediatrics and in the Peds ICU was to stabilize oncology patients and transfer them to Seattle. We really didn't offer anything at all to oncology patients up here. We didn't have the staff for it. We had an oncologist. She was primarily an adult oncologist, but we couldn't really give any chemotherapy or anything up here then. A couple years later, we started to be able to give vincristine, which ALL maintenance kids get once a month. That was really all we could do. Up until about 2006, Dr. Schultz arrived in Alaska, and she had, the goal of growing our program up here and allowing these kids from Alaska to stay in Alaska as much as possible. We had kids coming from villages that maybe had never even been to Anchorage, and then they come to Anchorage, they're diagnosed with cancer, and they are rushed off to Seattle where they stay for sometimes up to a year. Very hard on families. I mean, one parent or two parents end up staying in Seattle with the kids. They have to give up their jobs. They have to find somebody else to take care of their other children who are in school and need to stay in Alaska. So it was very disruptive to families. So when Laura got here, we started talking about developing a program. And our hand was kind of pushed in 2007 when we had a young man from Kosovo who was here and was diagnosed with leukemia. And because of his immigration status, he could not go anywhere else. He had to stay here. So we had a traveler, Bethany, who's in the room right now, was brought up here to not only take care of him, but to start training nurses, to start figuring out how to get our nurses trained so that we could take care of these kids up here as much as possible. We had some nurses who went out to Seattle for some training, and then Bethany kind of started doing the training program up here as well. So we were able to treat him here, his entire treatment. He never had to go anywhere else, and it was a very good outcome for him. Then around 2010, I think we did our very first ALL induction, where we actually got the patient, diagnosed the patient, and kept them here. Started induction, did their entire treatment here. And that's what we do now, basically, for all of our cancer patients, with the exception of patients with AML. They are treated so that their bone marrows are completely wiped out. They're very susceptible to infections. And up until recently, we haven't had HEPA filtration in any of our rooms on the peds floor. But just in the last couple, maybe last month, two rooms on the peds floor have been revamped, and they're going to have HEPA filtration. So we will be able to keep AML kids here as well. The other patients we don't keep here are some of the brain tumors, some of the patients with brain tumors. And that's mostly because we have some pediatric neurosurgeons that are comfortable with some of the resections of those tumors, but some of them they're not comfortable with. And so those kids usually go out to Seattle. So it was Dr. Schultz, and now we have 4 oncologists. We have Dr. Schultz, Dr. Norman, Dr. Whitman, and now Dr. White, who's just now joining us. She's also going to be part-time palliative care and part-time oncology. Dr. Schultz is the medical director, and Dr. Whitman is our principal investigator for the Children's Oncology Group. The Children's Oncology Group is a organization, it's a cooperation actually between many, many researchers from different states, different countries, all of them researching the best ways to treat these kids for their cancers. We became part of the Children's Oncology Group in 2013, which is a huge accomplishment for this small program in Anchorage. And it took a lot of work from many, many, many different people. We enrolled our first patient on a study in 2014. We currently have 16 studies open here in Anchorage. We don't always have a kid enrolled on every study. The large majority of our kids that are enrolled on the study are leukemia patients, and that is probably 85 to 90% of our oncology patients are leukemia patients. That's the number one cancer we treat up there. But we have a lot of others, a lot of solid tumors, and so these kids get to stay here and they do really well. There are many needs for these kids and their families. Like I mentioned, even still, now that they don't have to go to Seattle, some of them, all of them basically, who come from villages outside of Anchorage must stay in Anchorage for the least amount of time, probably 6 months. Sometimes kids have other health problems that make them stay here even longer. So one parent or both have to live in Anchorage with them, give up their jobs, find a place to live, find money to, live here. We have kids all of our kids need a lot of over-the-counter meds that help with their supportive care of their side effects of chemotherapy that are not covered by insurance. And so, we have a great social worker who will talk later about all of this too. But, we have to do better at providing these things for these kids. Like Emily said, and Nikki said, such a small percentage of the funds raised for cancer research and care are given to children. And it's pretty tragic, actually. And these kids grow into adults, most of them. It's very curable. I mean, you know, leukemia, 90+% live full lives. They do have a lot of side effects and long-term effects from the chemotherapies and the treatments that they receive. So we're caring for them for the long term, and for the long term, they need things. So I think that's all I have to say. We are happy to have our program here. We have a lot of people who support this program. Also, like Nikki said, our therapists, our teachers, our clinical research person, child life. A lot of people invested in this program and in these kids and families. Thank you.
Thank you, Rhonda. And I just wanted to highlight something that you touched on, but I think is worth mentioning. Testament to the Alaskan spirit. How we got the pediatric oncology actually off the ground was we got to do it, so we got to figure it out, which is how we get most of the things done in this state, honestly. Also wanted to point out that Dr. Laura Schultz, who could be with us this morning, was the first pediatric oncologist here in the state of Alaska practicing, and now all the pediatric oncology patients that are treated here in the state go through this one clinic with partnerships from all the other health systems around the state, which is also a testament to the Alaskan spirit and just making it work. So with that, we're going to switch a little bit and talk about palliative care with Drs. Terland and Timpane, and we have another quiz. So take your best shot, and then we're going to hand it over to the experts. Palliative care relieves suffering and improves quality of life for people of any age and stage in a serious illness, whether that illness is curable, chronic, or life-threatening. True, false, or unsure? Okay.
No.
There we go. The results are...
The results are... Yeah, there we go.
Okay, I'm going to hand it to these guys, and they can tell us what kind of nuance they want to put on this. So these guys are going to share the mic.
So I just wanted to spend a second reintroducing palliative care. I think that was a great start. So it really is an approach to care focused on the relief of suffering and improvement of quality of life, not only of the patients that we serve, but of the families that they're part of. For children, it might be their siblings as well. This approach is shared by everyone in medicine. So it's not just palliative care specialty teams doing this, but all of the primary providers, other people involved in their care, community members. Really, it's about the intent and the focus. So while certain providers might be focused on clinical outcomes, the palliative care approach is focused on what's important to the patient, what are they suffering from, and how can we improve the quality of life while partnering with the simultaneous goal of extending life, of perhaps curing the illness. It's really important, and it's a common misunderstanding that palliative care is only for people with a terminal illness. Certainly not, and particularly in pediatrics, often palliative care teams, which are usually composed of interdisciplinary members, physicians, nurse practitioners, PAs, social work, chaplaincy, and nurses as well. So really a true interdisciplinary approach to care. And these teams help with things like symptom management. They sometimes help with coordination of care, so bringing all the family, patients, providers into the same space to make sure they're in alignment and there's a clear understanding of the goals of treatment and an understanding and alleviation of any of the friction of having lots of different people in your care team. So that's one aspect of what we can do in addition to symptom management. And definitely in cancer care, we deal with mostly curable illness. And there's a lot of symptoms both from the treatments themselves, which can be pretty burdensome, and also from the cancer, of course. Palliative care, over time, teams will really get to know this family. We'll get to know the patient, what's important to them. And at critical junctures in time where there might be complex medical decision-making, we're often able to reflect on the values, on what's important to them, and help with more complex decisions. So really, by having that patient and family-centered focus, become hopefully a really valuable partner to the family and also to the primary providers, the primary oncologists, as well as a team who also is very keen to the values and what's important to that family. So that's kind of the approach. There's both the primary palliative care done by everyone in the healthcare team, and then the specialty palliative care, which may or may not be appropriate for that patient depending on the level of complexity of those needs. So that's kind of pediatric palliative care in a nutshell. I happen to come from Massachusetts, where I did my fellowship. One thing that they had that was really unique there was something called the Pediatric Palliative Care Network. This was a state-sponsored program where, via hospice agencies in the community, they provided palliative care support. So they used existing hospice staff to provide rural support. So it's usually a nurse and a social worker who could meet with families when they're back home in their communities, when they weren't in urban areas getting treatment, and be kind of eyes and ears, extra support. Patients who were on this did not have to qualify for the typical hospice benefit, which means you have to have a prognosis of less than 6 months. So this is widely used both by oncology patients as well as non-oncology patients, and was a great help to all of the families that I encountered in having someone at home with them, getting to know them over time, and these relationships would often go on for a period of years, so incredibly valuable. And then coming here to Alaska, I've been part of the team, the Tribal Health Consortium. We have been working on a perinatal palliative care program and hope to be involved in more pediatric palliative care with our patients here at Prov as well.
Thank you. I apologize for my voice. I'm at the tail end of a cold. So I'm a palliative care provider here at Providence. And here at Providence, we have both inpatient and outpatient palliative care for all age groups. Within the pediatric field, we're seeing perinatal patients. So these are families who receive a life-limiting diagnosis for their fetus during pregnancy. We see children in the neonatal intensive care unit, on the pediatrics floor, and in the peds intensive care unit. We also have an outpatient team that has a clinic here at the hospital and has some ability to do home visits for children in the Anchorage area. This is a smaller but growing part of our overall palliative care practice here at Providence. Outside of Alaska Native Tribal Health in Providence, there's another agency in town that's doing a lot of really wonderful work in palliative care and hospice for children, which is Hospice of Anchorage. They're a nonprofit organization that really focuses on providing good comprehensive care for families who are facing life-limiting diagnoses, both children and adults. On the pediatric side, they have a psychologist who's doing some really amazing legacy work with families. They have a nurse. The interaction with the nurse may be a little bit different than what people are more familiar with from more of a traditional hospice. It's more of a care coordination and not as much of a bedside nursing approach. And then they have bereavement services as well. Right now, their bereavement services are limited to the families for whom they have served the children during their lifetime. They also have a support group for families who have faced pregnancy loss and infant death. Within our community, within our state, we do not have formal, comprehensive pediatric hospice, and this is certainly an area for growth for us. In 2010, with the Affordable Care Act, there was a provision within that called concurrent care for children requirement. So this is a requirement of Medicaid that they cover services for children who have a prognosis of less than 6 months, both curative treatments or disease-directed treatments and hospice care. So children with a diagnosis or a prognosis of less than 6 months have the ability to receive both concurrent care. Also within the Affordable Care Act, there's a provision that allows for expansion of palliative care services. Not a requirement like the concurrent care requirement, but a provision that allows for expansion kind of on a state-by-state basis. This can either be done through an amendment to the state's Medicaid plan or through a waiver type program. California has been a bit of a model in this. They have done more of a waiver program. Without this program, really palliative care is only able to be reimbursed for the provider time, for the physician or nurse practitioner. And a waiver program really allows reimbursement for the nurse and social work time. And that is the bulk of the really important palliative care that's being done for these children. It's really that interdisciplinary team that Sean was talking about, your nurse, your social worker, your chaplain. And a waiver program allows some funding to be able to build things like that. In California, they've shown increased quality of life for these children and their families, increased satisfaction, and decreased costs. The decreased costs are primarily through keeping these kids out of the hospital. With these good interdisciplinary wraparound supports at home, children are spending less time in the hospital. When we think about growth for pediatric palliative care and hospice in our state, in our community, it really needs to be pronged for both hospice and palliative care. Right now we have a grant application in to support building a pediatric advanced care team. It would start with a nurse and a social worker who would really be kind of the legs of building formal pediatric hospice in our community. This is going to need to be a collaborative effort with all of the agencies and partners who are providing some of this work at present, but a lot of room for growth here. In addition to kind of meeting the financial needs, we also need to meet our workforce needs. Right now, there's some federal legislation, the Palliative Care and Hospice Education and Training Act. It's a bipartisan effort. I believe it has passed the House and is currently in the Senate. And this is something that will expand training and workforce development. So in addition to needing to provide funding for palliative care, we also need the people to provide the actual bedside care and the work for these families.
Thank you, folks. I just wanted to highlight one piece. You mentioned the hospice concurrent care for children in traditional hospice that funded by Medicare. If you enter hospice, you're not getting curative treatments. But the decision was made, and we can all understand why, that it wasn't fair to do that to children. That children should have every opportunity to take advantage of any new or upcoming opportunity and be getting the support of hospice at the same time. With that, I want to, before we move on to Stephanie, Tanya, if you could, we're gonna do another quiz here. This is a prelude to some of the things that Stephanie's going to talk about. What do you think are some of the biggest challenges faced by kids and families involved in cancer treatment in Alaska? So we have access to clinical trials, housing for families during treatment, insurance coverage and cost of care, mental health support, or I'm not really sure, but I'm about to find out. All right, everybody voted? Tanya, drum roll. All right, interesting. Mental health support is the runaway with 47%. There's a few of us, I answered, I don't know, because I answered before, pretending where my knowledge level was before I started working with the panelists. Access to clinical trials, housing. Those are some of the issues that Stephanie is going to address. Thank you.
Good morning. So I first want to explain what my role is, because oftentimes when people hear what a social worker is, they think OCS. I am not OCS. That is one of the first things I always say to families when I enter a room, because they immediately think that, why is someone coming in here that's a social worker? What's happening to my child? Is it going to be taken away? So the first thing I do is I say, I am not OCS. I have a really cool role where I support the medical team, but I'm also there to support families. Anywhere from mental health to resources to psychosocial supports to anything in between. I always tell families that if there's a non-medical question, to please ask me, because if I don't know the answer, part of my job is to help them figure it out. And I also have the wonderful support and get to work with our teacher and our child life specialists on a daily basis. And I just wanted to put a plug in for them as well. So I wanted to do an activity with you guys first. I want you to close your eyes and pretend that you are in a doctor's office or the hospital room with your child and you don't know what is going on, but you know it's something serious. And a doctor walks into the room and says, "I'm sorry, but your child has cancer." At that moment, think about what goes through your mind and the feelings that go through your body. You can open your eyes now. So typically, it's fear. Fear flashes through your body, and all you can think about is, my child has cancer. What? And then your mind goes blank. So oftentimes, families, it's fear. Fear of what's going to happen to my child. How are they going to get treatment? Can I stay in state? Can I return to my home? What's going to happen to my job? How am I going to pay for this? Where am I going to live? And that really is one of the biggest challenges. So for families here in Anchorage, oftentimes, and above, anywhere in Alaska, oftentimes at least one parent has to cease working or take a leave of absence from their job. If they've worked at their job full-time for more than a year, they can access Family Medical Leave Act, which is up to 3 months off. But if they've worked less than a year, then oftentimes their job is in jeopardy. There are numerous financial resources available throughout the country from nonprofits that we have access to, luckily. A couple of years ago we did not, but in the last 2 years we've really been able to make a network with these agencies to get support for families. And then luckily here in Alaska in the last 2 years we've had at least 2 oncology nonprofits that have started and have begun raising funds for our families to assist them, which is pretty amazing. Another issue, and I can talk about this for hours, so I'm going to try to just do brief things on each one, but another issue is medical coverage. We have a wonderful Medicaid system here in Alaska. I don't know if people always say that, but I do, because a lot of other states don't have the coverage that we have. Many of our families are on Medicaid, and oftentimes if they are, I think our team in a way sighs in relief, because it means that we have easy and quick coverage, that if they're from out of town, more than 90 miles, Medicaid will pay for their meals, their lodging, and transportation, which is pretty incredible when we have families that are having to be here in Alaska or in Anchorage for a year, or even for families that have to go out of state because Medicaid is helping them get there. One parent gets to go with the child. And so we have been lucky with the Children's Hospital. In the last about year and a half, we have been able to access apartments through our system that go along with our guest house, where we can provide an apartment for a family who has to stay here for a long time. And the Medicaid system actually is paying for that, which is amazing. The bigger issue, though, is when a family does not have Medicaid or IHS benefits, Indian Health Services benefits, and they're from out of town, because it means that we do not have coverage or a place for them to stay. And oftentimes this is a huge strain on a family. Luckily, Alaska has a program called TEPRA. TEPRA is a way to get Medicaid based on a child's diagnosis rather than the family's income, which is amazing, because it means that all of our oncology kids that are going through cancer care, cancer treatment, who have private insurance, they have access to this. The downside is it takes about 3 to 6 months to get. So as you can imagine, a family that's coming from out of town who doesn't have the funds for a hotel room and has private insurance, where are they going to stay? How are they going to survive? How are they going to put a roof over their heads? And how are they going to feed their family in addition to not being able to work? this is where I come in, and we have to get creative and figure things out. But we're still very grateful for Tetra. In addition, Alaska has another program through the Medicaid system called Alaska HIP, where once a child with private insurance does have Medicaid, the Alaska HIP program comes in and they will actually pay the family's premium, which is huge because it helps with that financial burden. So if you have questions about that later, I'm happy to talk to you about it. Another area that I focus on is mental health. Mental health through cancer treatment, as you can imagine, is really significant. We're lucky because we're able to provide that support from my role and also Child Life as well to support the families to help with that. But then when there's a higher need of anxiety, depression, or other mental health issues that may be going on with a family, accessing resources can definitely be difficult if the child has Medicaid. Here in Anchorage, we have very limited Medicaid providers for counseling. And so when it is identified that a family member or a child is in need of counseling to help support them as they're going through treatment or even after, we immediately have to get them on a wait list. And this wait list can be anywhere from 3 months to 18 months. So really the need for more medicated mental health professionals is huge. And I think Anchorage in some ways is actually lucky because we have providers. If you go to communities outside of Anchorage and you're looking for a mental health provider for a child or a family member with Medicaid, a lot of times you're going to come up without any luck. Fairbanks, very limited. Juneau, limited. Kenai, limited. And so then it just becomes either you're not able to get them treatment or you're having to work something out or the family's going to have to pay out of pocket. I'm trying to think what else you guys would like to know about. There's so much, but really just the need for more resources. I think housing, Medicaid, wonderful, like I said, but housing, mental health, and anything in between, we could definitely find ways of improvement. But we're lucky as it is, though, to have what we have.
Thank you, Stephanie. As we're moving further, I'd like to give a shout out to our UAA School of Social Work practicum student, Caleb Duplessis, who is our cameraman today. And Caleb is now going to take this opportunity to move the camera. Put this on the agenda so we remember to get this done. Move the camera so that we can move on to audience question and answer. We have some framing discussion questions. What networks and infrastructure need to grow to support kids with cancer? What policies need to change or be developed to support kids with cancer? And how can we better support kids and their families as they experience a cancer diagnosis and go through treatment and on from there? There are a few specific issues that have come up. We talked about just most recently mental health issues, housing. There are a number of other issues that we could discuss today, but I really want to give a shout out to the panel. Thank you for sharing with us so much progress. There's so much hope and promise in what we have done already in Alaska and what we can do. So thank you to the panel. Now, I have a few questions for the panel, but this is the audience participation opportunity. We have index cards on the table if you want to write a question and then just hold it up and somebody will come and grab it from you. Or we can also just take a raised hand and ask questions. We just have the one mic, so what I'm probably going to have people do is ask their question. I'll repeat it so that it's captured for the recording. We are recording this morning for the benefit of people around the state who are very interested in this conversation but couldn't be here in the room this morning. So I will open it up if there are any start-off questions. Senator Giesel. Go ahead. Yeah. You're close enough.
Sure, thanks. So actually not a question, a comment. We just heard about mental health services and Medicaid. So just to let you know, about 2 weeks ago, the governor signed my bill, which removes a major component of the 30% rule. So we've had a bureaucracy rule in place since about the 70s, which required a psychiatrist to be physically present in the clinic 30% of the time for clinical social workers, marital and family therapists, psychologists, and clinical counselors to provide behavioral health services under Medicaid. My bill removes the psychiatrist component and now allows a physician, in general, a physician, and the physician supervising does not have to be physically present. That person can supervise electronically. So either phone, internet, whatever. So this should open the door significantly to the 2,000 potential behavioral health service clinicians in the state. I'm working further with the federal government to look at how we get psych mental health nurse practitioners, specialists in behavioral health, to be able to do that supervision also, again, opening the door a bit wider. So there is hope on the horizon. That bill actually becomes effective in about 2 weeks. So hopefully behavioral health folks, clinicians, are contacting physicians who would be willing to supervise them.
That's exciting news. Another example of homegrown Alaska solutions. Thank you, Senator Giesel. Other questions and comments to get us rolling here?
I've got a question for you folks. About 25 years ago, when I worked at Denver Children's Hospital with the pediatric oncology patients, one of the biggest needs I had seen actually at the time was actually the siblings of the children who get neglected tremendously. What do we do about this in Alaska?
So we have a wonderful.
Hang on. I should have repeated that question. That was too far running. Okay, sibling care.
So our child life specialists, they're wonderful. They work not only with our patients, but also with the siblings to help them understand what's going on and to support them. I think that our child life department has definitely grown in the last couple of years. When I started here, there were 3, now there's 6. And we have an oncology one specifically just for us, which is pretty amazing. In addition to that, there are national programs that are going on, such as Super SIBs, that are made to recognize the role of siblings, to help support them and to make them feel important and understand their role in their siblings' cancer treatment, and to just be there to support them. But it's also ongoing conversations that we frequently have with parents about making sure that they're meeting the other children's needs, spending time with them, listening to them, talking to them, not only about their siblings' cancer treatment, but what's going on in their life, how's school going, sports activities, keeping things normal. Another big conversation that we also frequently have with families when the child is first diagnosed and throughout is keeping things normal, having your child have their expectations, having consequences for behaviors, because kids thrive having structure. And if they don't have that consistency, that's when they start to fear as well. Why am I being treated differently? And same goes for the siblings. So it's really important.
There are also some camps around that invite the siblings to come with the actual oncology patient. So the siblings get to be with them and meet, other siblings of oncology patients. That's really nice as well.
Thank you. Tanya.
I'm curious what the incidence of childhood cancer is in Alaska, and how do we compare to other states, and is it growing? And maybe you don't have that answer, but I mean, how large is the population of families that are dealing with this?
So probably at any given time, we probably have about 30 kids on active treatment. And that's really not including the kids who are just off treatment, who might be another 30. You know, we kind of, as I said before, we follow them basically through their lifetime. As far as incidents related to other places, I really don't have those numbers, but I think it's, according to the population we have, I think it's pretty steady across the states.
In your exercises. Do we differentiate much in the care for and the diagnosis and the barriers of care to younger children versus adolescents? Are they all kind of in one care category, or is there quite a bit of difference between the two?
As far as the actual treatment for the cancers of those two populations, they're a little bit different in, say, for the leukemia patients. The adolescents are higher risk, so they get more treatment, more intense treatment than, say, the littler kids would. As far as the supportive care and everything, it's pretty much the same across the board. We do, like the mental health aspect for the adolescents is huge, because we know that, you know, it's the time in their life when they're trying to become independent, show a little independence, and now they've got a cancer diagnosis, they have to kind of fall back on their parents, and it's really, mental health is big for the adolescents. That would be the difference.
You can take over anytime.
So to make this all work, we need doctors and nurses here. Do doctors and nurses want to come within an acreage? And if not, how do you fix that?
So we have, like I said, 4 pediatric hematology-oncology doctors now. We started with 1. So it is a good place. I mean, I think they have good benefits and pay, and they enjoy what they do. And then we have great nurses. We have 6 nurses who work in our outpatient oncology clinic. Each of them has a primary panel of patients. So they take on a certain number of patients, and they do all of their case management, and they take care of them while they're in the clinic getting their chemo. And then we have many nurses on the floor, on the peds floor and in peds ICU, trained to also give chemotherapy when they need to be inpatient for those inpatient stays. When we first started giving chemo up here, we did basically everything inpatient. And now, with the nurses we have and the staff we have outpatient, a lot of times the kids don't have to go inpatient, but maybe, you know, at diagnosis and maybe a couple other times throughout their treatment, barring any extra admissions for fever, neutropenia, or illnesses. So we do have a lot of great staff, and I think people do like to be here and enjoy what they do.
And then from the palliative care perspective, I mean, I think you're hitting on something. Recruitment is a little bit tough for physicians probably in general and nurses probably in general coming up here. We are doing a lot to kind of grow our own here. We have a really amazing interdisciplinary palliative care fellowship here at Providence, where we train a physician, a nurse practitioner, and a chaplain. It's a 1-year program. And I think if we can home grow these people, that can be really, really helpful. But there does have to be a component of recruitment and attracting not just the provider or the nurse, but the whole family to come to Alaska.
And I just wanted to go back and thinking about the different disciplines involved. We've heard a lot about child life, we've heard a lot about social work in the palliative care model and meeting the needs of these families. So much is not physician-based, and I just want to really stress the importance of that. And so really, if we could have more creative ways of reimbursing this care, because it's wildly inefficient. Like, it takes hours and hours and hours to really sort through the needs of a family, fill out applications for resources, which most families could not read an application and just do it themselves. They really need facilitated help. So I can't stress that enough. If there was better ways to capture the care coordination, the case management, all of the work, the conversations, I think you'd see more people wanting to do this work and there'd be more funding from facilities for more staff to do this type of work if it was reimbursed better.
I think, too, going back to your question about what we could do to help bring people to Alaska. So whenever I go to a conference or a meeting out of state, and I frequently go for the Bleeding Disorders Clinic, and the first thing anybody ever says to me when I'm from Alaska, and I'm sure you all get this as well, is, "You're from Alaska? How do you deal with the cold and the dark?" I don't think people realize what a wonderful place this is to live and all the great benefits that we have. And I think that in order to get good providers here, the first thing that we have to do is get word out and help them understand that they're not coming to live in this dark, dreary, cold place, but instead we're a thriving state with so many amazing opportunities, and what a great place to live. I think once people start realizing that, there will be a huge growth of people wanting to come here and work here and live here, because really the quality of life is amazing.
And as someone who recently came, it's the challenges of what we're talking about that's really stimulating. So if you're interested in problem solving and coming up with creative solutions that other states don't even have to think about, it's a place that really demands that. So the restricted nature of the resources we have creates more collaboration. So we're talking across institutions about how can we meet the needs of these populations. So that's really exciting, and I think it's a major recruitment edge, actually.
Thank you. So my name is Janice Park, and I'm a current candidate for State Senate. Also a former nurse, and I have worked in pediatric oncology and predominantly in the operating room. So my question would be, what proportion of your staffing are you able to do locally, both with nurses and support staff? And what would you need going forward to reach the goals that you would need to really fully implement your program from local staff? And I would anticipate that there would be some cost reduction, because I know travelers are fairly expensive.
So going forward, as far as providers go, one thing we would really like to do is do a lot more kind of outside of Anchorage outreach. We have a lot of kids up north that would benefit from us having a clinic maybe in Fairbanks once a month. We have a lot of patients, not a lot, but we do have people, kids from Juneau who don't really know a program exists in Anchorage, and they go to Seattle. So that's something we definitely want to work on in the coming years, is trying to get our name out there and say, hey, we have a program in Anchorage, come here. You know, it's closer, well, maybe not closer, but it's Alaska still anyway. As far as nursing, we have, like I said, 6 great nurses. We have travelers that do come when we have nurses on maternity leave or nurses that need to be out for any reason. But I'm sure, it would be nice to have, they do a lot of education. A lot of the case management that I'm talking about is our nurses go to the floor with a new diagnosis multiple times to make sure that those families are comfortable before they get their initial discharge. Because they have a lot of things that they've never had to deal with before. They have, maybe 10 medications, they have to watch for fevers, they have to know about their central lines, So it might be helpful to have, a little more nursing support for that, because the girls have so many other things they need to do as well. But in the main, I think we have a pretty good pulse on our program right now, and we have the needed staff.
I have a follow-up. One more question for our Dr. Doesn't help that they both start with T. For you guys, one of the things that came up in our planning around this issue and thinking about this issue, I loved when Dr. Ursula McVeigh mentioned how palliative care is different for pediatrics than for adults, because you don't go and say to a kid, let's work on getting your affairs in order. if you're facing an end-of-life situation. But, and I know that palliative care, we stress this, is more than just end-of-life care. It's a wraparound supportive care. But could you speak just briefly to the difference between practicing palliative care with kids as opposed to adults?
We both can. You know, from a provider perspective, as a physician, I kind of find really what services that these kids and families need. Sometimes there's pretty high intensity at the beginning, helping getting symptoms managed and kind of building that rapport with the family. But these are often long-term relationships that we're building with these kids and their families over the course of months and years. Sometimes a little bit different than in the adult world. And a lot of those supportive work that is done by palliative care in that long-term relationship is actually less done by the physician and more so done by the interdisciplinary team, by the social worker, the chaplain, the nurse. I think it's the kind of longitudinal nature that makes it a little bit different in pediatrics versus adults. And then the needs themselves can be a little bit different. It's truly that holistic supportive care that these families are needing and seeking that's provided by the non-provider member of the team.
Yeah, I would only add that, I mean, that's very, very true, the longitudinal nature. And while we do provide family support in adult palliative care as well, I think in pediatrics, so much of the patient's experience is determined by their family, whereas certain adults are more or less independent from their social support network. So a lot of focus is on the support of the parents, on the support of the siblings, because that indirectly affects the quality of life of the patient as well. So there's an even bigger focus and assessment of the needs of the family and siblings.
And we're going to take, we've got time for about one more question before we go over here.
Hi, my name is Pamela. I'm one of the managers of Pediatrics at Peds ICU and Peds Division. And I just wanted to comment on the question that someone raised about what we need in staffing. We actually have very little need for travelers. We have our own nurses who have been able to recruit and train and keep nurses who are interested and passionate about pediatric oncology care. But what we really need is that community support, especially at end of life and hospice care. We haven't been able to get that program running, whether we take it on as an institution, but as a whole, our community really needs a place for these families when we've reached the end of their life, and there isn't really good hospice care for them. And the families don't want to have a hospital death. They want to die at home. They want to be surrounded by their loved ones, their pets, whatever it is that the family is important to them. So that's really where we need the extra support, where we need the nursing support, the social work support, the palliative care and hospice support is growing that in the community.
Yeah.
So I'm going to put a plug in then for what we need a house, like a Ronald McDonald house. AMC has a Ronald McDonald house on the top floor of their guest house, but that is for Alaska Natives. It's not for people who are not of Alaska Native descent. In addition to that, it is oftentimes for pregnant women. And so when we do have patients who are Alaska Natives staying at the guest house there, they actually don't stay at the Ronald McDonald house. They have access to it up until usually I think it's about 10 p.m., but there is not a centralized house. In addition to that, this is a great opportunity to talk about oncology patients, but we have so many patients with chronic medical conditions who are not going through oncology treatment that I think oftentimes don't get talked about, whose needs sometimes are just as great, if not greater. And to be able to have a house that can be used by all of the hospitals here in Anchorage that is family friendly for children, where they can run and play and act normal and make connections with other families and have a playground and have meals brought in. That's something that we're really missing, that if you go to the vast majority of medical centers in the lower 48, they do have it. And consistently, we have families, oncology families and non-oncology families that I work with who come back and they talk about, oh my goodness, this wonderful place that we were at. I wish we had one here in Alaska. So figured I'd put a plug in for that.
I'd like to do a final lightning round with the panel. Because you kicked it off, Stephanie, with like, what's on your wish list? So Stephanie's wish list is the Ronald McDonald House.
And?
And?
The other wish list would be for Medicaid to pay for over-the-counter medications, because that is something that we continually struggle. Oftentimes, the doctors are prescribing things that are over-the-counter that Medicaid does not pay for. And when you are already financially strapped and don't have the financial means, it just puts more pressure on the families, and oftentimes they cannot afford it.
I have a big wish list, but the one thing I was thinking about when you brought up houses is eventually having a hospice house in the community. I have seen that be particularly beneficial for pediatric patients, because it's true a lot of families don't want their child to die in the hospital. However, sometimes it's very uncomfortable to bring them home, whether for siblings or for themselves. Some families feel like if that was to happen, they'd have to move because it's that significant of an event. And so the hospice house is a peaceful, open place where often allowing limitless visitors, lots of supportive services and therapies where a child could spend their final days. And so I have seen that work really, really well for families in places where the local hospice agency has been able to build a house, usually through foundation money or large donation. Various ways that those are funded, but can be really helpful. And then within the hospice benefit, or if there was expanded palliative care benefit in this state, families can get respite for children who have particularly demanding needs. So, you talked about the non-oncology population, but often it was at a hospice house where that could potentially be provided. So, pretty remarkable benefit to children.
And I'm just going back around to talking about hospice. I think when we talk about pediatric oncology, a lot of these kids do live. But for the ones who die and for the non-oncology children who are dying in our community, we don't have great support for them to die outside of the hospital. And building that team up as a collaborative effort across the different agencies, I think that is where we can have a huge impact. So formal pediatric hospice.
And I'll echo that as well. Thanks for bringing that up, Pam. It was in my mind and I just didn't mention it. We have had more than a couple, some children who have gone home in our community for end-of-life care. We did have a nurse that was working with Hospice of Anchorage who kind of helped these families. It was not sustainable for one nurse. It was too much. And so now we really don't have anything in the community for hospice. But I'm hopeful that we have this great group of people through the Pediatric Oncology team, the Palliative Care team, who are all really excited and energetic about trying to get that going in this state. It's hard, I think, to get funding for something like that because it does happen so infrequently. We do not have a lot of kids dying from cancer, but when it does happen, it is nice for them to be home. Another one of my wishes would be to be able to do some more outreach, and I think we're going to be able to do that now that we have Rebecca. Because it's going to free up some time for her and the other providers to maybe be able to go out and do some of that so that families around Alaska know that they have a place in Alaska that they can come for care.
Thank you. Let's give it up for our panel. Now, as we move into the next phase of what happens after this, you may be asking yourself, how can I help? Well, the American Cancer Society Cancer Action Network relies on people like you and our amazing partners, our sponsors again. Big shout out again to the Children's Hospital at Providence, Alaska Native Tribal Health Consortium, LIFT, Bristol Myers Squibb, Amgen, AARP Alaska, Janssen Oncology, and that fabulous social work class. And yay, Department of Social Work, thank you. On your tables, there are some forms, opportunities to join in our work by making a contribution to the American Cancer Society Cancer Action Network. So the forms should be on your table, and then there are envelopes to put that in when we're done. But I'd like to hand the mic now to Julie Wrigley, who is one of our ACS CAN volunteers, lead volunteer for the Anchorage area, to talk about what ACS CAN involvement means to her.
Good morning. What it means to me. I became involved with ACS CAN in 2014 after I completed, maybe it was during, my treatment for advanced colon cancer. And I was looking for, as a lawyer, sorry, but I do believe it's it is a helping profession, at least that's what I tell my clients and my students and myself. In any case, it's the only organization that locally affects policy, and a place where I can use my advocacy skills to advocate on behalf of all cancers, all people, every one of us, every single one of us is affected. Every single person is affected by cancer, whether we know someone, whether it's ourselves, whether it's a loved one, whether it's a pet. We're all affected, and the ACS CAN is the only organization I know of that actually advocates on behalf of everyone to end cancer. Anyway, that's what it means to me. Thanks for coming this morning.
Thank you, Julie. I believe the day that Julie walked into the office, she came straight from oncology rehab, our last session, into our office and said, now I got to do something more. So thank you for your support in our continued efforts. And once we have, we're doing all this work, but it really comes down to individual conversations. One of the things that Dr. Kelsey Terland mentioned earlier was something called PCHETA, because everybody in medicine loves acronyms. It's the Palliative Care and Hospice Education and Training Act. That is very, very, very painfully close to passing Congress. There's one more hurdle. We need to get it, it's already passed the House. We need to get it scheduled in the Senate Health, Education, Labor, and Pensions Committee, otherwise known as the Health Committee. We need some help from the Health Committee. You know who's on the Health Committee? Senator Lisa Murkowski. You know who's going to be going to see Senator Lisa Murkowski next week? Heather Arono. Heather Arono, with a couple of our other volunteers, will be leaving on Saturday to go to Washington, D.C. You want to say something about the letters you're just passing out?
Hi, everybody. My name is Heather Arono. I am the grassroots manager for American Cancer Society Cancer Action Network. So my job is to find people who are passionate about fighting cancer through policy and advocacy work and make sure they have the resources to do that. So the letter that we just handed out is to urge Senator Murkowski, who is already a co-sponsor for this important bill, to urge Chairman Alexander to set it up for a markup, which means that it will be set for discussion. This bill, the House version, just passed the House unanimously by voice vote in July. Doesn't happen very often, but the last time there was action on the Senate version of this was in March of last year. We are so close to getting this passed, and this bill would provide, I believe, 15 million per year, 10 of which would go specifically to medical providers, and another 5 million to education for nurses around palliative care. This goes to all clinics around the country. It's something that we've been working on for years, and if you were to sign this letter, a week from today we have a meeting with Senator Murkowski and her staff, and I and my volunteers would be very, very excited to be able to hand deliver this letter to her so that she knows that there are Alaskans back home who really want her to make this a priority. So, thank you. Please sign. Happy to answer any questions.
Thank you, Heather. So you can leave those also on your table when you're done. And that brings us to next steps. Next steps. We have another quiz just in case you had thought we were going to let you off the hook with more pop quizzes. This one is, there's a couple questions here. The first one is, what policy change or initiative would you prioritize to improve cancer care for kids in Alaska? Number 1, improved Medicaid travel support. Number 2, developing a Medicaid waiver program for pediatric palliative care. Number 3, passing the Palliative Care and Hospice Education and Training Act. Number 4, support for patient family housing in Anchorage. So these are just a few of the things that we have talked about today. What would your priority be? Just give whatever comes to your gut, first thing that comes to mind.
You can vote for more than a few one, right?
If you vote for more than one, will your first answer get deleted? Yeah, just pick. Don't worry, it doesn't mean we're not going to work on the other things. So just pick whatever you would prioritize. It's just a little brain teaser more than setting our agenda. So there we go. Support for patient family housing in Anchorage, followed by the Medicaid waiver program for pediatric palliative care, and Palliative Care Hospice Education and Training Act. All right, thank you. And then the next question, this is where your passion particularly lies. So forget what you think other people should be working on. If you were going to pick one thing for you to get involved in, what would that be? What policy change or initiative would you be interested in working on to improve cancer care for kids in Alaska? Everybody that just signed that letter, you all get credit for number 3 already. Thank you.
I already did that.
So you can move on if you like. All right, next. All right. Support for patient family housing in Anchorage. All right, I'm hearing some good conversation around that. Also, and the other things that we talked about, the working on improving palliative care access in the state and passing that darn federal legislation. So we will get that done. The last slide, this is our evaluation slide. So why don't you go back, can you just skip ahead to the sponsors for a second? We'll go back to that evaluation. Oh, whoops. Actually, now that you guys have already seen the evaluation slide, let's go to this one. I would attend another ACS CAN policy forum in the future.
Just when the results aren't going to be shown.
The results are not going to be shown to this, so no pressure. Just want to gauge general interest.
For administrative purposes.
For administrative purposes only.
Right.
All right, now you can go back to the sponsor slide. I really want to thank everyone for being here. You've been a wonderful, attentive, interested group early in the morning. Let's give another round for our panel. Thank you. And thank you again to our sponsors. And with that, you're welcome to get some more food on your way out the door. Thank you for coming and look forward to continuing this conversation.
And remember
to get back the clickers. Don't take those with you. There's nothing else to vote on. Thank you so much, everyone.